Let's get started, Dr. Khalid, please.
Okay. Yeah, good evening, everybody. I am Khalid Swefi. I believe most of you know me. I'm a consultant critical care and head of ICU department in Eastern Province of Saudi Arabia. So today we'll have a webinar and we'll talk specifically about renal nutrition and what is new when you are talk about renal nutrition. First, I'd like to introduce my great friend, Dr. Amr Al-Husseini. He is a professor of nephrology at the University of Kentucky in US, and he's the president of the World Institute of Critical Care and Emergency Medicine. Floor is you, Dr. Amr.
Thank you so much, Dr. Khalid. It's very nice to see you today and to see this gathering. And I'm very happy to announce for our first program in the World Institute of Critical Care and Emergency Medicine. And this program is the Intensive Care Nutrition Program. And Dr. Khalid actually is a program director. So just some background about the World Institute of Critical Care and Emergency Medicine. It's a non-profit organization built by physician for physician. And our aim is to improve our emergency medicine and critical care medicine clinical practice through comprehensive education to our healthcare professionals. We are starting with the first program, which is focusing on the nutrition care in critical ill patients. Then we will have our second program in cardiac critical care. And then we are going to have a focus program, point of care ultrasound, and also a neurocritical care fellowship. All of our programs are high quality education at affordable rate. As we are a non-profit organization, we love to give you the up-to-date standard of care and information that helps you to improve your clinical practice. Again, education, knowledge doesn't have any value without implementing it in our clinical practice and improving our patients' outcome. I wish the best for you, and I'm very happy to be here today, and I'm very sure that we are going to learn a lot from Dr. Khalid and Dr. Wafa and Dr. Osama. Thank you so much.
Thanks, Dr. Amr. So I'm going to share with you the first talk. So as Dr. Amr mentioned, we are going to establish the new Institute of Intensive Care and Emergency Medicine soon, and we'll start with the Nutrition Fellowship. Actually, we dream to have this kind of institute since very long time, and finally we can see in 2025 real. Actually, what I'm going to talk about the fellowship called Intensive Care Nutrition Fellowship, which comes into two different flavors. Critical care, which is how to deal with life-threatening emergency while stabilizing the patient. At the same time, we need to focus on nutrition. So nutrition, whatever oral, enteral, or parenteral, does make huge difference with the patient. If the patient, for example, is deficient in micro or macronutrient, and you have a great depth, it ends with really catastrophe of worsening outcome. So while you are managing or establishing life support procedure, don't forget that nutrition is part of that life support procedure. And in our fellowship, we're going to teach both adult, pediatric, and neonates as well. So the Intensive Care Nutrition Fellowship is a treasure, comes into through modules over 1 year time. The first module is around foundation of intensive care nutrition, is around 16 weeks. And the second module about total parenteral nutrition, adult, pediatric, neonates, around 16 weeks. And the latest 16 weeks will be about advanced critical care nutrition, where we are going to learn about renal, we are going to talk about microbiome. We're talking about different really subcategories like a transplant, nutrition, as well as oncology, and how to feed patient at the end of life. Detailed program will be having special webinar. We'll talk about a detailed program and how going to register for it. So important really to understand that crystal clear that intensive care nutrition fellowship is very beneficial and very unique and running by people from different parts of the world, from different disciplines, and they are all senior people working in the field of nutrition for a very long time. So you have to learn the role of the game, and then you can play better than anyone else. Have a lovely day, and it is my pleasure to introduce Dr. Osama Tabara. He is my great friend since I was in Cleveland Clinic, Abu Dhabi, 20 years back or 15 years back. I know him very well. He's very senior senior pharmacist, was a director of Cleveland Clinic organization at that time in the pharmacy department. Dr. Osama Tabara is also the president of the IV parenteral nutrition or TBN parenteral nutrition network, and has a lot of fans all over the world. So the floor of you is you, Dr. Osama, and thank you very much.
Thank you, Dr. Khalid, for the introduction. Assalamu alaikum jami'an. Good day, everyone, and very warm welcome to the Intensive Care Nutrition Fellowship series. I'm delighted to have you join us today for this highly anticipated session. Our focus for today's webinar is on a critical and significant topic: what is new in nutrition in renal diseases? As you know, renal diseases continue to pose a considerable challenge globally, and the role of nutrition in managing these conditions has become more important than ever. In this webinar, which is around 1 hour webinar, we aim to explore advancement in nutritional assessment and novel therapeutic approaches that are transforming patient outcomes in this domain. To guide us through this important discussion, we are privileged to host two distinguished experts in the field. We have Dr. Wafa Ayesh, an esteemed authority in clinical nutrition with vast experience in applying innovative nutritional strategies. And the second presentation by Dr. Khalid Swaifi, a leading voice in renal nutrition and metabolic care. Each of our speakers will present for 20 minutes, providing their insights on the latest advancement in renal nutrition therapy and assessment techniques. Following these thought-provoking presentations, we will have a dedicated 30 minutes Q&A session where we will address your questions and delve deeper into this vital subject. So we advise really to put your questions and answers on the QA sections, and we will be definitely covering all your concerns and questions. So I encourage all of you to actively participate. Your engagement will enrich today's discussion and ensure you maximize the value of this session. Once again, thank you for joining us. Let's dive into today's program, where we can uncover new possibilities in nutrition and its role in transforming care for renal disease patients. Today, we are a gathering of more than 500 delegates. Here, I would like to thank Fresenius Kabi for supporting this educational event. And once again, thank you for joining. With that, let's get started. And I'm thrilled to introduce our first speaker, Dr. Wafa Ayesh. Dr. Wafa is currently working as a consultant clinical dietitian and head of nutrition department at Al Tadawi General Hospital and Medical Center. She's a former consultant at Public Health Protection Department, DHA, and a former director of Clinical Nutrition Department, DHA, with over 30 years of expertise in providing clinical nutrition support. She's a certified specialist clinical dietitian and nutritionist with master's degree in nutrition and food science from the USA and a certified ESPN teacher with diploma in clinical nutrition and metabolism. At a personal level, Dr. Wafa, she's an amazing friend of me, not only to me, to all the nutrition community. We are very glad to have you, Dr. Aish, for the 20 minutes, coming 20 minutes. You will be speaking on new nutritional assessment in renal disease, and the stage is yours. Dr.
Thank
Wafa.
you so much, Dr. Osama, for this introductory. I'm honored and privileged to be with you. You can see my slides? Yep. Okay.
Dr. Wafa.
Yeah, thank you, doctor. Thank you so much. Okay, I'm gonna talk about the guidelines for nutrition assessment and screening for renal patients. It's a broad one to cover it in 20 minutes, but I'm gonna take you like in a tour of what are the things that we really need to look into it with for renal patients. Okay. Now, we all know that we have CKD, non-dialysis patients, and they focus on slowing the disease progression, prevention of malnutrition, and managing dietary intake based on their GFR. Also, we have the renal patients who are on dialysis, where they require more frequent monitoring and stricter nutrient fluid management due to their losses during the dialysis. Also, we have the post-transplant, which we focus on shifting to maintain a healthy weight, managing side effects of medication, and liberalizing the diet. And then we have the acute kidney injury, where the assessment is dynamic and it is tailored to acute phase, emphasizing on immediate metabolic demand and fluid management. I think Dr. Khalid will go in depth, but I thought I will share with you a bit of what are the types that I'm gonna talk about. Now, from all of that, we come to that nutrition is a cornerstone of renal care. It is not just about survival, but also thriving. Chronic disease, chronic kidney disease, and end-stage renal disease, they are major global challenges. Do you know that in 2017, which is a few years back, it was 850 million with CKD? They are expecting in 20, of course, 11% of cause of death in 2019 was because of the kidney diseases. And imagine, they are expecting that it will take the rank of 5th cause of death by 2040 if we don't do something. So we have to do something for, that's why I'm here, and thank you for Dr. Khalid and the team that they are really taking care of that. Proactive nutrition assessment, it is a must because it is tailored and vital for enhancing the renal care. So what is the best way to detect CKD? We do initial testing. We all know the lab results. And we, according to the Kidney Disease Improving Global Outcomes, they have a breakdown suggesting ways to use the GFR and the ASR throughout the CKD patients. Well, the KDIGO clinical practice guidelines for the evaluation and management of kidney disease, they provide a very comprehensive where you can all even download it free for the clinical practice guidelines, evaluation and management of chronic disease, kidney disease. You can see the full comprehensive recommendation, but I summarize it in tips like the definition. They go for the definition and the staging of CKDs, which is defined by decreased glomerular filtration rate less than 60% ml per minute per 1.73 square meter, or a marker of kidney damage using the albuminuria for more than 3 months. And also there is the risk assessment that The guidelines use the GFR and the albuminuria categories, A1, A2, A3, to satisfy the CKD risk and progression. What does it mean? That when we go for the albuminuria as a marker of kidney damage, the categories include that A1, when we have normal to mild, less than 30 milligram per gram, while the moderation, A2, it is 30 to 300 milligram per gram, where the presence of albumin in the urine, which indicate a structured kidney damage, which is very sensitive marker for production progression and adverse outcomes. When it goes to A3, that severe, more than 300 milligram. Higher albuminuria level are independently associated with a greater risk of CKD progression, cardiovascular event, and even leads to mortality. So that's why it's very important to do the proper intervention. Both the GFR and the albuminuria categories together enhance the risk of satisfactions, because a patient with a mild reduced GFR, for example, like G2, but they have severe albuminuria, A3, for example, they may have a higher risk than the patient who have moderately reduced GFR, example G3A, but there's no albuminuria A1. So we have to look into everything, both together, which can give you a good structure to know. We have to monitor, we have to check the anemia and the bone disorders. It's a very important guidelines providing and managing the CKD related complication like anemia, mineral bone disorder. We have to make sure that they are referred to nephrology, focusing on the advanced CKD and their rapid progression. And also we have to put the goal to reduce the CKD progression. Now, when we go for assessment, there is from 1987 till 2019, and now I will put also the 2024, as you can see in my slide. They start only with the subjective global assessment, going to more depth, even the MAST, even the mini subjective, even the more powerful, led to the GLIM, which is the Global Leadership Initiative for Malnutrition, that have been started in 2018, implemented in 2019, but still under more studies on the effectiveness of that. And there was published that by Barrel, that this screening and assessment in chronic disease, Kidney News in 2024, that we should use all what we can for the assessment of our patient in the right way, to see that when we do this assessment, we can check the nutrition risk of malnutrition, we can see the prevalence of malnutrition, and by nutritional screening, we can have a persistent method for nutritional status to identify the patient risk of malnutrition. What else? When we do the initial screening, there is the timing of screening, which is conducted upon initial diagnosis for renal, and then we repeat it every 6 months, for stable patients, and monthly for those on dialysis or with rapid changing condition. This is the initial. Then we go for screening steps, taking the patient's history. We document the weight, the changes of the past 3 to 6 months. We review the dietary intake. We check and note the symptoms affecting their intake, like nausea or poor appetite. What else? Also, we do the clinical assessment. We identify their physical signs of malnutrition, such as muscle wasting or edema. We evaluate the presence of comorbidities or complications. What else? Then we go for the patient subjective global assessment. This one, it's a simple one like you see on this side, where you take the weight changes, the dietary intake, the gastrointestinal, if they have any kind of symptoms, the functional impairment, and the physical examination. Easy to plot, easy to identify, and in that you can check everything related to your patient's intake and whatever they have in pain, nausea, pain, constipation, or others. So for adaptation for this subjective global, I put these steps for you. Adaptation for renal patients. For kidney disease non-dialysis, we focus on detecting the early protein energy wasting. We track the stable weight, and changes masked by fluid imbalance. For the patients who are on dialysis, we do some adjusting by considering the fluid retention and the change in the dry weight. In symptoms, focus includes complications like nausea and dialysis patients related to fatigue. For post-transplant, we monitor the post-surgery nutrition recovery and the impact of that, and we assess the patient's weight gain and metabolic syndrome. For acute kidney injury, we make sure to track any rapid changes in nutrition, and we identify any kind of risk of refeeding syndrome or acute protein energy defects. And that's based on this global assessment. We score it, we check it, and we put, after we fill this, there's a scoring comes out for us from 0 to 4 or higher. What does it indicate? If it is 0 to 1, that means he is fine, he doesn't have any malnutrition, he doesn't have any problem, no intervention required at that time. 2 to 3, the scoring, that means a little bit of counseling should be there, a little bit of education should be there. And if it is from 4 to 8, nutrition intervention, it is needed, and the dietitian intervention with a proper regimen for that patient should be there according to their needs. And if it is more than 5, critical needs for nutrition support supposed to be there. GLIM criteria, and this is, as I said, it had been introduced in 2018 and implemented in 2019. And the GLIM criteria, it is very easy. It is new approach that offers a framework for diagnostic malnutrition in adult patients, include 5 practicable indicators that can be easily used. Clinicians are encouraged to complete a comprehensive nutrition assessment after they use this base. It gives you an idea where is your patient. And very simple, if you can see this graph here, the flow chart that shows that GLIM criteria, we do the screening, any screening tool you have, the MAS, the NRS 2002, any screening tool. Then we do the further assessment, subjective or others, and we have to use the GLIM approach by including one phenotypic criteria and another one which is one phenotypic and one etiologic criteria. The phenotypic criteria, which is detecting the weight loss, the low BMI, or a reduced muscle mass. You will tick easily, yes or no. And then the etiological criteria, where you have the reduced food intake, yes or no. If they have disease, inflammation, yes or no. Now the diagnosis, if you have 1 + 1 of any, that means it's a risk. And then we go for saying the severity of the stage, depending on these numbers, which I will explain in a bit. The applicability of the GLIM criteria and CKD is still being developed, and further studies to be there for them. Now, this is in depth. We look into the phenotypic criteria, where there is an intentional weight loss more than 5% within past 6 months, and or more than 10% beyond 6 months, Also, we look into the BMI if it is less than 20 for the age of 70, in Asia less than 18, and if it is less than 22, if it is more than 70, and in Asia less than 20. Muscles if it is reduced. And I'll tell you how we will use it in a bit. Etiological criteria also, we check the, as I said, the food intake, if they have any problems in that, and also if there is any kind of disease burden. Now, the severity grade, we have stage 1 and stage 2. In stage 1, both stage 1 and stage 2, if they have require one phenotypic criteria to meet this grade in both of them, in stage 1 and stage 2. But we have to look into the etiological criteria to judge if those patients malnourished or severe malnourished, moderate or severe. If they are moderate, if the patient, they have the weight unintentionally 5 to 10, severe if it is 10 or 20, okay? Also moderate if the low BMI from the phenotypic criteria, as I said, 20 or above less than 70, or 22 if it is more than 70, and the reduced muscles. With one of any of the etiological criteria, as we said. So one of plus or minus of those criteria can show the model, 1 plus 1 of them, one of the etiological plus one of the phenotypic, and then you can judge that this patient might be on malnutrition, moderate or severe. The first step is to detect the nutritional risk that can perform well, and by nutritional screening tools, which you have in your premises, and several parameters to diagnostic protein energy wasting in population with CKD undergoing dialysis. A single marker by itself is not able to identify the diagnosis of nutritional disorder. So you have to make sure that you are doing a proper investigation. So for protein energy wasting, it's where it is a condition that a patient of nutritional and metabolic degenerament commonly observed in patients with chronic disease, kidney diseases, which is characterized by progressive loss of protein stores and energy reserves, leading to a muscle wasting, fat loss, which ended up with malnutrition, severe malnutrition. Also, we have the anthropometric measurement. If you remember, I said GLIM, we use it to check that they are under malnutrition, and then we go for further studies to identify it. We go for dry weight for dialysis patient, for body weight. We monitor the trend rather than the single measurement. We check the body mass index. We adjust for fluid overload as well. We take the mid-arm circumference and the triceps skin fold thickness to indicate the muscles and the fat storage. And for the dry weight, especially for dialysis patient. Why is that? Because it refers to the dry weight after dialysis session when excess fluid has been removed, leaving only the weight for their body without any extra water retention. So it is a must to take the dry weight. It is the target weight where the patient is neither over dehydrated or overhydrated. Now, the biochemical parameters, we all take in consideration the serum albumin and the prealbumin, the C-reactive protein, serum creatinine and urea, as well as the potassium, phosphorus, and sodium level, which all of them have an indication to show us if our patients under malnutrition. Now, something we all taught as a nutritionist and the clinical dietitians, and as well the physician, we all know that the albumin and the prealbumin, they have a half-life. So we have to take in consideration that when we check our patients. Now, the dietary intake, we have to take both 24-hour recall plus the food diary. Why is that? Because most of the time people, they don't remember, and it relies on memory. So the food diary will give you exactly what are the patients are taking in calorie intake, protein consumption, electrolyte fluids, and fluids intake. Also, the physical examination, where we assess the capacity and limitation, evaluate the signs of muscle wasting, edema, or any fat loss for our patients. We use the functional assessment, and this is we use it with the GLIM and with the subjective assessment. Hand grip strength, it's a marker that you can use in bedridden patients, where they can just use it and put their hand grip strength, which evaluate the CKD. Does it be enough evidence? Do we have enough evidence? It's a trial-based, still under investigation, but it helps you to have a little bit of knowing where is your patient's muscles lay on, and if they have enough muscles, especially with hospitalized patients. Also, the stages of chronic disease is very important to look on how much protein should be given in each stage, stage 1 to 3, stage 4 to 5 with non-dialysis, calories amount, all of that we calculate, and we monitor their potassium, their phosphorus. We encourage each stage different type of diet accordingly, and the dietitian is taking each one individualized and calculate accordingly. Like, for example, dialysis patients, we increase the protein intake from 1.2 to 1.5. We liberalize the potassium, phosphorus, and fluid intake based on their requirement, individualized requirement. Also, we go for specialized assessment. We have something called for dialysis. We have the residual renal function, where we use it to adjust the protein and fluid intake. We go also for the intradialytic nutritional support, where we consider the parenteral nutrition for those patients with poor intake. We go for vascular assisted access, where we access for infection, inflammation that may affect their nutritional needs. So when we take these patients, we take in consideration everything for those patients to make sure that we are doing the proper regimen. After all of these assessment and screening, we have to put the goals and the intervention to prevent the protein energy wasting. So early identification can prevent that protein energy wasting. So we offer oral nutrition supplement tailored for renal patients, renal specific formulas. We make sure to check the electrolyte management. We adjust the dietary intake based on lab results and symptoms. Like I said, all those labs should be there to take all in all the status of our patients. We go for the fluid restrictions. We educate them on the fluid management to prevent any overload. We look for our micronutrients to provide vitamin D, iron, folate, and B vitamins if it is needed. We avoid any over-the-counter supplements with potassium or phosphorus unless it is needed. We monitor, we follow. I'm ending. We do the monitoring and follow-up. We regularly assess the patients, and we adjust dietary recommendation, and we document for our patients. We educate and we counsel. It's a multidisciplinary, and it's very important. By the guidelines of 25 and 24, 25, these are the summary. You can just take a photo of it. All the purpose to prevent malnutrition, make sure that we have a proper weight gain. We use all the screening tools that we can use, the subjective, the GLIM, and also we look into the nutrition indicators, which are the lab tests, and we make sure that accordingly, the calories are needed. Similarly, for the proteins, electrolytes, micronutrients, fluids management, dietary restrictions, and body composition is a must. We take it with, as I said, the BIA, the hand grip, whatever you have in your hospitals, and frequency of monitoring according to the case, and special consideration. It's a must, especially if we have protein energy wasting. All these are found in the global outcome with the KDIGO. You can download Aspen guidelines. They are all there. And by that, I end my talk, and these are my references. Thank you very much.
Thank you, Dr. Wafa. Very enlightening presentation. In fact, you have summarized a full chapter in 20 minutes, and you made it really crystal clear for all of us. Of course, we have so many questions. We will be addressing them at the end of this webinar. Now it's my honor and pleasure to introduce our second speaker, who's really very well known to you. He's our leader, Dr. Khalid Al-Swaifi. Dr. Khalid is the head of AICU Consultant Intensivist. He's the chairman of Parenteral Nutrition Committee at King Fahd Military Medical Complex. He's the editor-in-chief of ICU Gate, and he's editor as well in more than 5 international journals, including AGACC and SAM. He's the president of Critical Care Educational Support Professionals Group. He is a very active consultant in nutrition in the Gulf region. He is considered a celebrity in the world of critical care nutrition. Over the next 20 minutes, Dr. Khalid will be addressing the novel nutritional therapy in renal diseases. Excellent. You know, I'm happy to see more than 500 delegates joining our webinar for today. Dr. Khalid, تفضل.
Dr. Osama, thank you very much. Okay, so I'm talking about nutrition in renal disease and what's new in 2024 and 25. I'll speak about the novel therapy, and let us to see together how can we do. Actually, novel therapy started to be in everything. They can see the AI really a huge advancement in the AI. Also, despite that advanced technology, we still can see patients dying from renal failure all over the world, and you can see a lot of patients or millions of patients progressing from CKD stage 3, 4, 5 to end-stage renal disease and to be dialysis dependent, which is really very sad for us. And we need to do extensive work to improve the outcome of these categories of patients. So what's new? What's new? Everything now having new tools, like in cardiology, have a lot of advances, and the coronary angiography, and in the cardiac surgery, and ICU, a lot of advances, also mechanical ventilator, CRT, and also. But what is new really to help patients with the CKD to prevent? You look at this Swedish scientist when he developed nanobots capable of destroying cancer cells from inside. This is the way of really tackling chronic disease. So we need to really think outside the box and to use extraordinary things. So regarding the kidney, we know that the kidney is the superstar organ, and we know clearly that disorder in the kidney will lead to the huge disorder in the metabolism, especially the nutrient-related metabolism. And the net result will have a patient with refractory hyperkalemia, refractory hyperphosphatemia, autonomous hyperparathyroidism, and severe metabolic acidosis. Metabolic acidosis itself is catastrophic because it causes severe muscle wasting and cause severe bone demineralization, and the net result of the patient frailty score will be totally decreased. Malnutrition in the kidney disease is a kind of tragic, costly, and very common. It's around 42% in renal disease, and dialysis patients suffering more than non-dialysis patients. And the malnutrition is multifactorial. We know that a lot of problem related to malnutrition due to poor intake from the uremic toxin and severe anorexia. Patient is scared from protein, so it's decreased dietary protein intake and muscle wasting, as well as we have a hypercatabolic state coming from toxins released from the circulation, and especially from the liver metabolism of the amino acids. So proper diet counseling and lack or poor monitoring of the nutritional status will add more to the risk. So what's the goal of nutritional therapy in renal disease? Number one, we need to prevent deficiencies, reduce uremic symptoms, improve nutritional status and quality of life. Number two is crucial to really control the edema, electrolytes, and acidosis. Number three, we need to prevent what's called CKD mineral bone disorder, which is really cause sometimes pathological fracture, and patient will be bed bound. We need to provide individualized plan to each case according to the lifestyle of each patient. So standard management is well known to everybody, the diet, which is usually DASH diet, correction of acidosis, dialysis, a supportive management if reached end-stage renal disease, and don't forget to use active form of vitamin D, phosphate binders, and finally the oral nutritional supplement really to augment the nutritional support for this patient. For the diet, we know that the DASH diet is a standard, which is a low in salt and rich in fruits, vegetables, whole grains, low fat dairy, and lean protein. And KDIGO guidelines 2024, they mention clearly that CKD patients should receive sodium less than 2 grams per day, or salt, sodium chloride, less than 5 grams per day. So here, some people telling that, oh, how to use high dose fruits and vegetables, which will end with hyperkalemia. We'll learn together what we need to do. Actually, we have a clear scientific evidence that if you get higher total vegetables, it's correlated with high eGFR. It's a linear correlation here. You can see the higher the glomerular filtration rate is going with the higher veggie intake. When they look at the veggies, they look at the nuts, berries, which is the highest really vegetable associated with a better outcome. Also, they found the sardines and the low beef diet. So high sardine and low beef diet associated also with better outcome. So if the patient left with hyperkalemia, what you are going to do is very, very important to understand. So if the patient left with hyperkalemia, those kind of patient like having stage 4 renal tubular acidosis, you need to reduce the potassium and sodium content of diet, and this patient veggie need to be sliced, peeled, soaked, and the best technique is called double cook method. I can see a question in the chat box, like telling like what to do to reduce quantity of potassium in food and to get benefit from the fruits and veggie at the same time. So here you need to have a double cook method. You cook the veggie and then you kept it until dry, and then you pre-cook again, which can reduce the potassium and salt content by 50%. Alpha calcidiol or active form of vitamin D is KDIGO, sorry, what's called the Kidney Foundation guidelines, like telling clearly that recommend patient to have vitamin D to be assessed, especially if the parathyroid hormone more than 300 Bg per ml. And target range for parathormone to be 150 to 300 Bg. So if the patient kept with hypocalcemia, it will end with increased parathyroid hormone release, and later on it will be called tertiary hyperparathyroidism or autonomous parathyroid gland, will work automatically. If the patient still malnourished, you go for renal formulas, and renal formulas here, like for many of the containing 1 to 2 kilocalorie per ml, and protein is actually containing only 6 grams per 200 ml, containing lipids, which is actually modified fat rich in omega-3 and rich in medium chain triglyceride as well, and to be electrolyte restricted here, so phosphorus, sodium, and potassium, especially in the pre-dialysis patient who is really need to control all this issue. But again, a lot of CKD patients, they have a normal potassium level, and they don't have a trend to higher potassium level, especially if only as they're stable. And those categories of patients, you need to really supplement the potassium because potassium is associated with less cardiovascular event. And you know that patient is dying from renal failure due to a major cardiovascular event. So don't underestimate the effect of using potassium, especially from natural sources in patients with renal disease, to reduce hypertension, to reduce incidence of MI, stroke, and any kind of ventricular arrhythmias. So what's new? I think all of you say, like, oh, we know all these things, but what's new here in 2024-25? We have to understand that to have a CKD stage 4-5, or to have even renal failure and dialysis is not a death sentence. It should be a wake-up call, not a death sentence. And here you have to be careful and take care of every single step in your life. And the best thing to do, number one, is exercising. And we know that even minor exercise, which is walking, which is the king of exercise. We have a study has been published yesterday showing exercising at 6,000 steps, or walking, sorry, for 6,000 steps is associated with 60% reduction in the all-cause mortality. So just by simple walking a day, 6,000 steps, you're able to reduce the mortality by 60%. So in adult, it's important to understand that inadequate dietary intake, especially the micro nutrient like vitamins, has to be supplemented. And the best patient to benefit is patient having dialysis. I think I have a question now also in the chat box and asking this question. Why you need to supplement vitamins and which kind of vitamins is the best? I can tell you exactly, a patient is having very poor intake, very poor absorption because of the integrity of the gut is lost, and also having loss of the vitamins in the dialysis session. And the important use essential element, trace element, and vitamins. The most important one is vitamin C, folate, and thiamine. And thiamine is crucial for carbohydrate metabolism or for Krebs cycle. So without thiamine, you cannot really have an energy. So don't underestimate the effect of thiamine or vitamin B1. Omega-3. So it's important to have an omega-3. Yes, omega-3 is very crucial, and fiber also is very crucial. And this study has been also look at the fiber and omega-3, found linear correlation between using a high fiber diet and omega-3, diet rich in omega-3, and the progression of CKD and survival. So important to take a diet rich in omega-3 fatty acid, and we look at sardine here, and salmon as well, or you can take omega-3 supplement from outside. And important also to take fiber, and we learn together that fiber is fermented by the gut microbiota to produce short-chain fatty acid. Short-chain fatty acid is associated with better kidney function, improve GFR, reduce all-cause mortality. You have to understand that our microbiome and kidney, they have what's called bidirectional relationship. So when you have a high incidence of bad microbiome like Enterobacteriaceae families, and low incidence of helpful microbiome like Bifidobacterium and Lactobacilli, you will end with significant worsening of the urinic toxins. The urinic toxin release will be intensified, the absorption will be intensified, and the recycle will be inhibited. So it ends with catastrophe of the uremic symptoms. If you have the opposite, you will end with better quality of life and less uremic toxins. The highest amino acids, which is really cause uremic toxins, as a precursor like phenylalanine, tyrosine, and tryptophan. So renal failure patient trying really to reduce those kind of amino acids. But the message here is need to improve the helpful gut microbiota to able to improve the outcome of this category of patient. Also, when you have CKD, you have a disruption in this gut microbiota. So the gut microbiota worsens kidney function, and the kidney failure will worsen the gut microbiota. Also, we need to hear about what's called Akkermansia or AKK. Akkermansia has been, I think, the latest microbiome or latest bacteria has been invented or discovered in the gut in 2004. And the Akkermansia actually is one of the family, one of the 20 group of microorganisms present in our gut, and is present in the mucosa, so-called mucosal associated microbiome, not present in the gut lumen. That's why we, the scientists claim that the AKK is responsible for to maintain the gut integrity. And when the gut integrity gets worse, when patient is NBO or having severe hypercatabolic state, also the Akkermansia is deficient and will end with catastrophe of renal interstitial fibrosis. So animal study proves that Akkermansia is really associated with worsening of CKD, and we would like to see, we have a small studies in human showing the same, but we need to see really a randomized control trial, large randomized control trial to prove the effect of using Akkermansia and the probiotic supplement to reduce progression of CKD. Protein supplementation. So should get protein supplementation or not, and what kind of protein you need to get. And you need to understand that protein, reduction of protein really can slow progression of the CKD due to reduction of nitrogenous waste product and reduce burden on the kidney. But at the same time, protein is helpful because our hormone made of protein, our receptors, our enzymes, our collagen, our muscle, hemoglobin, channels in the cells, all are made of protein. So what is the guidelines telling about protein? We will start with 0.6, 0.8 when you have a CKD without acute illness. When patients have acute kidney injury hospitalized, you go with 0.8 to 1. When you have a patient with critically ill AKI, you go 1.3. And when you have a critical ill on CRT, there's been guidelines telling you go up to 1.7, has been still going to 2.5 because huge loss of protein in the circuit of dialysis. So a question here, is it possible to reduce protein to 0.3 to 0.4 per kg per day without muscle wasting, and you will get benefit from slowing the progression of CKD or not? Answer is yes. How to do that? The only way to do that is using keto-Ka or keto analogs of amino acid. What's keto analogs of amino acid? If you look at here at the diagram, how is the protein metabolized or catabolized, you will find clearly that the protein will be denatured by HCl in the stomach, pepsin, trypsin, chemotrypsin into amino acid, and then amino acid will go to the liver through the portal circulation, and in the liver they are undergoing what's called deamination or transamination, and they will leave the amine group. And this amine group will go to the urea cycle and to be converted into urea. So, and the carbon skeleton will go to TCA cycle or Krebs cycle. So if you supplemented with keto analogs of amino acids, the keto analogs, they don't have this amine group. They have only the keto acid here and will go to form energy and build up muscle. So it's very, very intelligent idea to use keto analogs to improve the outcome of this renal patient. We have in the market many keto analogs now, especially after the National Kidney Foundation 2020 strongly recommend use it. BioKidney, most of them either magnesium-based or calcium-based. Keto sterile also is available in most of the Gulf area. It's not available in Saudi Arabia yet, but soon will be available. And the dose should be 1 tablet each 5 kg body weight, taken during meal and swallow whole. And we have enough evidence now to show that using low protein diet or very low protein diet with keto sterile or keto analogs, amino acid reduce or delays the onset of dialysis and reduce the major acute cardiovascular event. But you need to monitor calcium level if you're using calcium based. And we have a new study published in 2024 using keto analog called C2LAN. And C2LAN is a combo of these keto acids in addition to citrate, calcium citrate, and in addition also to inulin. And they found, after reviewing the article, they found clearly that this kind of strategy really is slowing down the progression of CKD and improve quality of life of CKD patients. Usually they are starting between stage 3 to stage 5, but the most benefit coming from stage 4. So why need calcium citrate and inulin and Ka combo? We know that Ka reduce nitrogen waste production because there is no amine group in that kind of keto acids. The insulin here, the inulin here significantly fermented by the gut microbiota and release short-chain fatty acid which reduce uremic toxins and also reduce interstitial fibrosis in the kidney. The calcium citrate, the calcium can correct the low hypocalcemia and the citrate corrects the acidosis to reduce also the muscle protein wasting. So all can able to reduce progression of CKD and the initiation of dialysis will be delayed. National Kidney Foundation guidelines strongly recommend Ka supplement, Ka and supplemented with very low protein diet, and the condition patient CKD stage 3 to 5 and should be metabolically stable, not metabolically unstable. The first study done in non-diabetic patient, but now we have also a new study has been published in diabetic patient, but should be stable diabetic patient, not unstable. I don't bring diabetic patient with blood sugar is 500 and give him keto analog. What about the Arabic gum or gum Arabic GA? I think you heard about it, especially when one lady published an article. Her daughter was in peritoneal dialysis, and they delayed the peritoneal dialysis for almost 1 year or more when using extensively the gum Arabic. I know it is not standard of care so far, but it's one of the tools really to slow progression of kidney disease because it has strong anti-inflammatory and anti-apoptotic as well, so reduce the cellular apoptosis at the level of the glomerulus. We have a study, randomized control, have many studies done in Sudan, prove that this kind of GA working in renal disease, but we have also a new study in 2021, randomized control trial in all 70 patients. They use oral GA at 50 grams per day for 3 months versus placebo, and they look at the glomerular filtration rate declining or increasing, and they look also in the creatinine, serum creatinine, and they look also after 3 months for 6 months to see if there is any improvement even after stopping this kind of GA or not. They found that gum arabic increased eGFR by 4.8 ml per minute and decline in serum creatinine by 11%, which is statistically significant difference, and GA positively influenced the rate of progression of CKD in human, and that effect persists for at least 6 months beyond the period of administration. So it's very, very, really simple way to use it, and I use it for many of my patients. I can see the lowest creatinine level for patients who are getting the Arabic gum or gum arabic. And you can see here the study after 3 months get higher GFR, and still higher GFR continued for 6 months, but than the pre-level, but not the same, of course, as patient was getting gum arabic. That's called acacia gum. Then we go for IV amino acids. Should we use IV amino acids really to prevent AKI or not? And the rationale of using IV amino acid is to improve the renal blood flow in acute kidney injury patient, or patient has a high risk for acute kidney injury. This is a study has been published in August 2024, randomized trial intravenous amino acids for kidney protection in post-cardiac surgery patient. They selectively use the cabbage coronary artery bypass graft. And the very large studies enrolled 3,500 patients from 22 centers all over the world. They use IV amino acids at 2 grams per kg per day for 3 days, post cabbage versus lactated ringer. And primary outcome was occurrence of AKI, and secondary outcome was severity of AKI. They found statistically significant difference in the primary outcome among adult patients undergoing cardiac surgery. IV amino acid at 2 grams per kg per day for 3 days reduce occurrence of the AKI. So I think we should change our clinical practice based on that very strong article. Another study still did not yet publish. It's called Nexus trial. They use IV amino acid in addition to cyclic exercise, and there is standard of care, and I think it will come positive as well. Intradialytic parenteral nutrition. Also, a lot of people asking me, should we use it? I believe now the Center of Excellence for dialysis are using intradialytic parenteral nutrition, and it should be a standard of care for patient who is not able to comply with nutritional assessment, and you'll find them like undernourished, hypercatabolic, undernourishment due to poor intake and increased loss, and hypoalbuminemia as well. And dialysis session, 15 to 20% reduction plasma amino acid level per dialysis session. 15-20% is huge. Will impair amino acid availability for protein sense. And also we have a catabolic state, so cytokine activation will increase muscle protein breakdown and increase the release of amino acid from the muscle, and net result of protein energy wasting. That's why we thought that IDBN or intradialytic parenteral nutrition through using hemodialysis access, we don't need to use other access than HD access for delivery of parenteral nutrition, and allow delivery through the venous drip chamber in the extracorporeal circuit. So the simple way to hang on the ready-to-hang formula and administered through hemodialysis catheter, session around 4 hours, 3 times a week. So it will be very, very helpful for the patient. Study mostly done for 3 months, and they able to show that improve significantly the nutritional status of the patient and improve all biochemical parameters targeting improving dry weight. So I believe if your patient at dialysis center, this message for nephrologist, is malnourished, consider to use IDBN safely without any problem. So if the albumin indication, or if albumin less than 35 and unable to tolerate oral nutritional supplementation, is the indication to use IDBN based on the study published in 2022, and they found clearly that albumin get higher after 3 months, dietary intake get higher also. So when you're able to improve the protein supplementation and the supplement the efficiency of vitamins and minerals and amino acid, it will end with improving your appetite as well, and body weight get higher, and the malnutrition inflammation score get lower. So what about the peptides? So now is the 2024 was the year of novel peptide, because if the first peptide which get abundance is the what's called the GLP-1 agonist like Mounjaro or Ozempic, and they're able to reduce significantly the gastric emptying and reduce the appetite. So peptides start to get really a popularity at that time. So peptide, to get it short, is a kind of short module of the amino acid. So you have a polypeptide which containing around 20 or higher amino acids. Here the peptide having like 2 to 3, sometimes higher, but is really less than 60 or 50 to tell it is a peptide. And peptide, because it's very tiny and very small, it can cross the nuclear membrane and go to the chromosome and DNA and really change really the gene mutation if there is a problem with the gene mutation issue, fix the gene mutation issue. So we have a 2 peptide which is important for the kidney. SS31 is actually ameliorates the apoptosis and reduce the oxidative stress and fibrosis by regulating the mitochondrial dynamics. And the SS31 is can actually go into any kind of mitochondria, not only renal disease. You can fix any kind of really disease related to mitochondrial dysfunction. So it's very, very, very good peptide. The mitochondrial peptide MOTS-C has protective effect against renal disease, especially patient is having what's called diabetic renal disease by mitigating mitochondrial energy. So peptides are bioregulator. It will be really a standard of care soon in the coming 10 years, but still the evidence is not that strong in human. We have very strong evidence in animal, but we don't have strong evidence in human, but we have a lot of in vitro really trial showing it is positive, and a lot of individualized really experience with using peptide, especially BVC157 to heal the like joints or bone or whatever, and SS31 in mitochondrial dysfunction. So take home message, current guidelines telling clearly that we need to change our dietary pattern, and to go to DASH diet or Mediterranean diet. When you go to plant-based unprocessed protein, can slow the trajectory of eGFR decline, reduce risk of kidney failure, and reduce mortality and improve quality of life. So really, by modifying diet, you might change your life. When you go to organic diet, you can stay away from cancer, for example. And routine requirement, we have patient with CKD stage 3 to 5. You go to 0.8, sometimes 0.6, but the KDIGO is still going with 0.8. Adult with CKD at risk of progression, avoid high protein, more than 1.3. Patient elderly with malnutrition, consider high protein and calories target. A CKD with progression, you need to have a use very low protein diet, 0.3 to 0.4 gram per kg per day, supplemented with essential amino acid or keto analogs up to 0.6 gram per kg per day. Energy requirement should be high in patient with CKD. Critically ill CKD post-transplant is 25 to 35 kcal per kg per day. Non-critically ill 30-35 should not be allowed less than 20-25 kcal per kg per day. In AKI and CRRT, in diet calorimetry is the most accurate method, because you can find a lot of discrepancy between the diet calorimetry and your simplistic equation in the calculation. So every patient should have any patient should have a dialysis chart containing what he should get from calories, protein, and micronutrient, and omega-3 fatty acids, and medium chain triglyceride. And they need to have a supplement with keto analogs or not, micronutrient or not. How much potassium should be getting, how much phosphorus should be getting, vitamin D, all this stuff. At the end, really you need to tackle patient with CKD aggressively before going from stage 3 to stage 5, and before going to initiate dialysis. And even patient on dialysis need to improve their quality of life to go back to their ordinary life. I'm always telling, if you cannot go back to your ordinary life, it ends with you lose the reason to be survived. So our role as a healthcare worker to bring back the patient to their ordinary life and to live his normal life activities. Thank you very much, and the floor for Dr. Osama.
Thank you, Dr. Khalid. That was really a timely presentation and very up to date. It's very nice to know more about the keto analogs, and we have so many questions addressing also this in this context. طيب, let's start with questions and answers. I encourage all of you, if you have any Q&A, please type it under the Q&A button. The first question, Dr. Khalid, let's start, because we have 2 or 3 candidates asking how do we register for CCN and CCN program. So,
I think let me to write the registration link so they can go and register on the chat box.
Excellent.
So you will find here in front of you, just to go and register. Payment is not yet decided. It depends on the cost of the course, still under processing. So just only register your name and your interest to be with us.
Okay, since Ramadan is coming, we have questions from Mahmoud Abu Aslih about your advice with the CKD patients during Ramadan.
Yeah, for the fasting is very beneficial, by the way, because fasting can improve the autophagy, and we can get the luxury of having greater autophagy when you have a dry fasting, even more than weight fasting. So I advise all CKD patients to get fasted to reduce really the catabolic toxins, which will be released from the uremic toxins metabolism. And I advise to get supplement. The first thing to take after they start to get breakfast is to get supplemented with protein, whatever it's a natural protein source, if they can get, or you get keto analogs of amino acids if you are stage 3 to 5, or to get even essential amino acid, which is being far better even than the intact protein as a nitrogenous waste product. Calories should be high during the period of eating, because as we know also the calories is important, but in general fasting is in the favor of the reduction of the toxins from uremic metabolism.
Excellent. Dr. Wafa, if you can turn your video on, we have a question for you.
Yeah.
As you know, the GLIM is not yet fully validated as a assessment tool for renal patients. So we have a question here asking about your experience in using GLIM for renal patient, and when do you think that will be a highly recommended tool for renal patients?
Actually, it will be very soon. It's there in the guidelines, the new guidelines to be used for them. But when we applied in 2018, it had been down. We did the research while I was in the Government of Health on the admitted patient, and there were a few of them with renal problem. We used the hand grip. And there was a question about the hand grip, by the way. If there is a cutoff point for CKD, there isn't. It depends on hemodialysis and dialysis, and I answered this question, by the way, on the chat. We used the hand grip and we used the BIA, plus we did the GLIM. And you will be surprised that we find out that most of 56% of the people were already malnourished on admission. And that's why it's really important, very important tool. At least we went into further assessment, more subjective assessment for our patient to make sure that they are on the right track.
Excellent, thank you. We have a question, this can be answered by Dr. Khalid or by yourself, Dr. Wafa. The role of vitamin B12 supplementation in dialysis patient, even or especially if the levels are normal. Is there any evidence of using B12 routinely in those patients?
I can answer this question because we know clearly that the gut lining is get disrupted during especially CKD stage 4 and 5 and dialysis patient, because of the atrophy of the parietal cells, so or auxentic cells of the stomach. So the HCl is less and the intrinsic factor is less. So we don't expect that they can absorb vitamin B12 in a proper way. So most of patients on stage 4-5 dialysis, they should supplement it with vitamin B12. If vitamin B12 is normal, I don't know. I don't trust really the vitamin B12 level because when I do it in any patient in ICU, I found it normal, which is unlikely. I think you would supplement without really looking at the level.
Can I add something from my point of view as a dietitian? I add my voice to Dr. Khalid. By the way, vitamin B12, we all know that it's a water-soluble vitamins, which are usually lost during dialysis and may be insufficient with most of the low protein or controlled protein diets. So commonly it is supplemented because, as you've said, it is usually not trusted with the results. You are absolutely right. So you can see it and you can observe it. That's why we supplement it.
Excellent. And as a pharmacist, I would say you have always to look into the reasons, like if the patient is getting metformin or proton pump inhibitors or aspirin, here probably vitamin B12 is worth the intake. Okay, we have a question about if there is any research comparing albumin versus total iron binding capacity as a biochemical parameter to assess nutritional status in end-stage renal disease. This question is by Hiba Musharrafi.
Yes.
Are you aware of any research comparing albumin versus TIBC?
And for me, I don't know whether Dr. Khalid have seen any.
I don't know actually.
Me too. No, I didn't. It didn't come across me that there is a study regarding that.
Excellent. We have a question. If the patient is CKD stage 4, at the same time has bed sores grade 4, what is the protein requirement in this patient?
Here is the time to use the keto analogs. You don't have other option because if you go very high with protein supplementation, it will end with worsening of CKD. So here is the place or the location where the keto analogs does have a great impact on that. Use essential amino acid also as well if you don't have a keto analog. Use rather than whole intact protein. And arginine here has a role also because can really increase blood flow to the wound and improve wound healing.
Can I also add something?
Collagen.
We use usually when they have sores, we use, there is a product that we use that have arginine, glutamine, and HNBs. And that one, usually it is controlled carbs as well. So we can give it to that patient if you don't have the other one, yes. And it have a very excellent results on bed sores. Excellent. It have arginine, glutamine, and HNBs.
Excellent. Which brand is available in our region, Dr. Wafa or Dr. Khalid?
I can say.
That's no problem. People are looking for a product. So if you can mention more than one brand available.
I know one that I use. Actually, even I propose it in a poster in an excellent results with Gargarine as well. I used Abound actually from Abbott, and it was an amazing product, honestly.
Yeah, we have two other products. One from I think Meditation. It's called Argiment, which is in powder form, and we have the formula from Nestle. It's called Impact. Impact containing arginine, high dose of arginine, plus nucleotide, plus fish oil as well.
Excellent.
But
We have
we
a
sure
comment.
what there is a protein required, because still protein is high in this kind of format. So we need to
The
be
one
careful.
the one which I use is usually it have arginine, glutamine, and HMB. That's it. It doesn't have any other things, and it's really good.
We have a comment from Jayan Vidayan. Thank you, Dr. Wafa, for a wonderful presentation. So,
Thank you.
okay. Ian Mutuma, is it necessary to supplement vitamin C for CKD patients?
Yeah, as I mentioned, one more very essential vitamin 2 supplemented was lost a lot, especially during the circuit of the dialysis, as the vitamin C. And also vitamin C is very crucial for iron metabolism, iron absorption, to change ferric iron to ferrous iron. So vitamin C is very crucial for CKD patients because most of them have anemia as well.
Excellent. You know, I like this question by Muniba Akram since it is relevant to my specialty. Muniba is asking, first she's saying wonderful session. So what about the renal patient having TPN with lipid and ultimately getting sepsis and fungal infection due to dialysis and catheter, etc.? So what's your advice?
We'll leave it for you, Dr. Osama.
Well answered, Dr. Osama. This is your specialty.
Yeah. You know, it's a myth that, you know, we have to stop lipid or reduce lipid in case of sepsis. But during, you know, a septic shock, we tend to reduce the lipid to 0.5 to 0.7 gram per kilogram per day. We don't overdose lipid. It's a trend born in practice, but in general, let me say it clearly, there is no absolute contraindication of using lipid in septic patients. This is in brief.
I agree with you, but I need to tell her that any patient who is metabolically unstable is better to withhold the parenteral nutrition or any enteral nutrition until he's stabilized. But the focus first on stabilizing patient maybe take 24 hours or more than that, and then later you can restart slowly. So, but there is no specific issue for lipids itself, especially when we have this new SMOF lipid and all stuff, which containing high omega-3s and the old intralipids, containing omega-6 based.
Excellent. And we have an interesting questions by Guglu Lethu Mangoma, how to manage taste alterations in renal patients. And here we have to think about the zinc, etc.
Yeah, I agree with you. So here zinc, that has really zinc deficiency.
Yes.
It's very, very crucial for the taste problem. But very important thing here, I noticed when I'm treating patients with hyperemesis gravidarum, severe anorexia nervosa, like if you replace the nutrient, especially the trace element deficient, you'll able to bring back the patient to his ordinary life as his appetite will be great and all stuff. So even replacement of micronutrient itself will able to bring patient back to taste the food.
Excellent. We have a question from anonymous attendee. He's saying, thank you for an amazing presentation first. We are receiving so many positive comments on this amazing webinar. He's asking, may I know how are keto analogs administered for patients for CKD stages 4, 5, who is not on dialysis?
Yeah, we'll use the one available in the Middle East is called keto sterile. Is I think Fresenius product. You get 5 gram per 5 tablet per so 1 tablet per 5 kg. So if the patient is 50 kg, you need 10 tablets. You can distribute it if you want because it's quite high, 10 tablets. This is a way of getting, and you achieve around 0.6 gram per kg per day based on keto analog. So what you do exactly is the patient will get better not because keto analog get better because reducing the intact protein down to 0.3 to 0.4, not from the keto analog. Keto analog will help you to achieve the protein target without really increasing nitrogenous waste production. So again, you get this one tablet per 5 kg body weight, actual body weight. I would like really to see the company, like if people from Fresenius here around, I would like to thank them very much for sponsoring the event. But also, why not really to have a formula, yani nutritional formula like enteral or oral nutritional supplement containing those categories or those kind of keto analog rather than tablet, which is not really ideal for patient in the hospital. So maybe in the coming few years, we'll find this keto analog, especially after getting more evidence, nutritional formula or nutritional supplement containing this kind of keto analogs would be easy to be supplemented.
Excellent. We have a question here, if there is a role of nutrition or any nutritional intervention in preventing pruritus for dialysis patients. Tough question.
Oh, dialysis. No, it's not tough. We have as a nutrition diet from dietary, yani.
In general, يعني إنه we need. Can we prevent pruritus for those patients nutritionally?
Nutritionally, I am not aware about something can prevent pruritus, but what I know now from new dialysis filters are really ending with very low incidence pruritus. And now I think there is one also CSL Behring. They have a new drug which really stop pruritus totally in patients who's having some sort of refractory pruritus. I don't know actually exact name because it's just new to the market, but it's available now everywhere. So if so dialysis, especially when you do CVHDF or convection plus the diffusion, you will able to remove the cause of this kind of pruritus. If left still with refractory, use this new CSL product, which will be very effective.
Dr. Bashir is asking, he's saying wonderful presentations. Can I know what is the TPN rate that can be given in an hour for intradialytic TPN? Actually, I intradialytic TPN for many years, so we have great experience. Usually, from my point of view, we give a 500 ml over the period of dialysis, which is over 3 to 4 hours. In general, it's 100 ml per hour. What's your experience in this, Dr. Khalid?
I use 1.2 liters. We use, according to the latest study, we use 300 ml per hour for 4 hours. So the session is 4 hours using 300 ml for, so we'll use it for 4 hours. This is according to the latest study.
Okay. Keto analogs, are they available in powder as well on top of IV or only IV?
No, it is present in oral.
Oral formulation. Okay. But IV is available, right?
I'm not aware. I hope it's available, but I'm not aware.
Okay. Can those keto analogs be given to unstable patients?
No. Yeah, the keto analogs, because the keto acids, it is written clearly that has to be given metabolically stable patient.
I see. Dr. Vidayan is commenting that he has experience with vitamin D, B12, and omega-3 that can help pruritus as well.
Great.
Thank you for this great lecture from an anonymous attendee. Any randomized controlled trials for keto analogs? We have no experience in it in some of the Gulf countries. Apologize if I missed it. So it's worth repeating and guiding Dr. Khalid for the best randomized controlled trials from your point of view.
Yeah, there is many randomized controlled trials. The problem, it is not that large. Based on number of low, but the latest randomized controlled trial has been done in Mexico and has been published in August 2024, and revealed also the keto analogs really does reduce really the all-cause mortality because of reduction of nitrogenous waste products and reduced burden on the kidney. So there is this.
There is a question by EH. How do you define metabolically stable patients in CKD?
It's a very difficult question, but the patient usually doesn't have severe rearranged metabolism in the form of electrolytes. For the patient with severe hyperphosphatemia, hyperkalemia is metabolically unstable. Patient with severe hyperglycemia, unstable. So any problem with really homeostasis is called metabolic inactivity or metabolic instability. This is my answer.
Okay. Ian Mutuma is asking, what's your take on supplementing iron for CKD patients? What you do advise in cases where you can do ferritin levels often?
So ferritin is not accurate, of course, because of the acute phase reactant. So and they can be associated with hypercatabolic state. But ferritin is good to assess your general health. And for example, like when I'm doing for myself labs, regular labs, when I'm donating blood or whatever, so I am usually looking at my ferritin level. I'm trying to keep it between 50 to 150 because the higher ferritin level is associated with the higher incidence of coronary artery disease and acute cardiac death. So, but in CKD patients, the story is different because they are usually having a problem with anemia, and they're not able to utilize iron even because of the lack of erythropoietin. You can track to do it to assess the acute phase reactant, but really rely on the iron level to give iron or not.
All right. We have a question by Dr. Mustafa Ahmed. Thank you for a great presentation. What about the evidence for ketogenic diet in refractory SE?
Refractory SE, what does mean SE?
I'm trying to figure out what's SE. It's okay. We'll go back, to this question later. Any maximum number of calories that you can recommend, Dr. Khalid?
Maybe, sorry, Dr. Maybe mean about status epilepticus.
Refractory.
So SE here, ketogenic diet is standard of care.
Oh, yes, standard of care, exactly. I'm
It's
linking
away
it to
from our-
renal, but I couldn't find, yeah.
It means that any patient on super refractory seizure is getting 3 drugs or more should be on ketogenic diet. And this is very crucial. And I can see patients cured totally from seizure when they shifted to ketogenic diet. And here you have to go with very high even fats to able sometimes to in patient with super refractory to reach to 80 to 90% fat, not only 70%, to able to cure this kind of disease. So it works in Alzheimer and works in refractory status epilepticus.
Bashir is asking maximum calories that can be given orally during dialysis to prevent hypotension. I'm not aware of hypotension-induced calories, but any recommendation about the maximum number of calories, Dr.
Maybe he means that during the dialysis and you're giving total parenteral nutrition. I believe that. And we usually stick to 2 grams per kg.
Yeah. Bilal Ashraf, very nice and very insightful knowledge. Dr. Wafa and Dr. Khalid, he's very thankful. Thank you, Dr. Bilal, for attending this webinar. Anonymous attendee saying how to face the challenges in maintaining dialysis patients' weight. Interesting. This is a textbook, probably.
You have to do all what we are talking about.
Exactly. You have to go for all the above. Check the protein, give the vitamins, making sure that you're giving enough calories. So it's all in all. Yep. It's evaluating and individualized approach, actually.
We have 2 questions on arginine. Would you still use arginine enriched formula if the patient is admitted to the medical ICU?
Yeah, I don't have any problem with that. The arginine is a precursor of amino acid. Arginine will be converted into nitric oxide by arginine nitric oxide synthetase. And the nitric oxide is a molecule of the century. It will increase blood flow to the vital organs, increase blood flow if they have a tissue injury or whatever. So the only issue with arginine is because of vasodilator, if you have a patient who is septic shock or distributive kind of shock, it is not really preferable because cause more hypotension. But otherwise, you don't have concern. Even patient is stable shock.
These are the guidelines anyway. That's true.
Due to time limitation, we'll take one more questions by Sheikh Al-Sawafi. As dialysis patients needs more high protein, at the same time, we need to address the phosphorus intake. Is there any recommended way to achieve the need from protein from meat, but avoid phosphorus high intake at the same time?
Yeah, all of them, they are getting sevelamer.
Yeah.
So here you can get really the protein without push about the protein. So in association with sevelamer.
Excellent. Excellent. You know, I would like to thank you, Dr. Khalid, for the opportunity of moderating this session. Dr. Wafa, that was an amazing seeing you again and listening to your presentations. That was really very interesting webinar, very up-to-date, very insightful, informative. And I'm happy to see that until now we have around 400 patients until the last minute of the webinar.
Thank you.
Thank you very much. With this, we conclude our webinar for this evening. Thank you, Fresenius, for supporting this education event. And have a great night if you are in this part of the world, or have a great day if you are in North America.
Alaikum assalam. Thank you so much. Thank you so much, everybody. Good night.
Thanks for attending. Thanks for Fresenius. Bye-bye.
Thank you.